So tonight I'm gonna discuss the latest and most advanced techniques for the treatment of degenerative spinal conditions. Degenerative spinal conditions are those conditions which occur over time, such as aging, wear and tear, repetitive trauma. I'm going to focus on three major diagnoses: spinal stenosis, spondylolisthesis, and degenerative scoliosis. Lower back pain has become the #1 leading cause of the expenditure of healthcare dollars in the United States today. And that's due in part in the fact that it is so common. Everybody during their lifetime, virtually 100% of people will at some time experience back pain and sciatica, which is a pinched nerve and pain going down the legs. Also, the population is aging and people are becoming a little bit heavier. It's also due to the fact that the surgical procedures are becoming more complicated. And as they become more complicated, certainly they become more expensive, but they also become more minimally invasive. And what that does is that opens up the opportunity for people to have spinal surgery who really haven't been a candidate for spinal surgery in the past. We can now do people that are much larger, older, treat spinal conditions successfully that we could not treat in the past. And basically this is driven by the fact that society demands better results, more reliable results, and less pain. And I think these newer techniques certainly help us deliver. When you look at back pain, you divide it into two major classes. You have acute back pain and you have chronic back pain. Acute back pain typically resolves in 6 to 12 weeks, rarely needs anything surgically, never. Chronic back pain typically will resolve in 12 weeks, 6 months or longer. Some of those individuals may need surgical intervention. When you look at the causes of back pain, it's divided into two major causes. You have soft tissue causes such as muscles, ligaments, tendons. Those type of injuries tend to respond spontaneously. The other causes are those causes that involve nerve roots. If there is some spinal cord impingement, a certain percentage of those people may go on to need something done surgically. That would include such things as degenerative disc disease, spinal stenosis, spinal malalignment, scoliosis, those types. Conservative treatment options include physical therapy, medications, epidural blocks, chiropractic treatment, acupuncture. But if all of those treatment options fail, then we think about what we're going to talk about tonight, which is surgical intervention. It's important to keep in mind that though the surgical procedures have become much less invasive and much more successful, the actual indications for surgery have not changed. We still want to exhaust all the conservative treatment options first. Some of the advantages when you compare the minimally invasive surgery to traditional surgery: if somebody has, for example, a traditional fusion, they'll be in the hospital 3 to 5 days. They may not start walking till the second day. With the XLIF, about half the people go home that day, about the other half go home the next day. I cannot remember, somebody staying longer than just one night. With the XLIF, with the traditional surgery, you're going to stay 2 days long. You're not going to walk until the second day, probably not go home for 3 to 5 days. With the traditional surgery, with a large open wound, frequently you're going to have to donate blood preoperatively. It's not uncommon for those patients to have blood transfusions. In the case of the XLIF, we've never had a patient that's actually had to have a blood transfusion. Return to normal activity. In the case of an XLIF, typically in 4 to 6 weeks, you can get back to normal activity. I've had an opportunity to do several surgeons and physicians lately. I did Dr. Alma Lemez's husband, who was playing tennis at 6 weeks. In the case of traditional surgery, people continue to have pain for several months. Certainly you don't get back to normal activity for 6 months, and probably that tissue, once damaged, never heals completely. Another thing that's not mentioned on this slide, but probably should be, is surgical time. With traditional surgery, especially in the case of a revision, it can take several hours to do that surgery. In the case of the minimally invasive surgery, it takes several minutes. One of the things that makes this possible is for the first time ever, we have real-time, live-action spinal cord monitoring, a device that will map out the nerves. It tells us where we are in relationship to the nerves, and more importantly, where the tip of our instrumentation is in relationship to that nerve. Just getting close to the nerve, the device can measure how that nerve is functioning and tell us the health of that nerve. Once we put the disc in, the pressure is relieved from that nerve, and hopefully the device will go from red to yellow to green, showing all of us that the nerve is functioning better. This is degenerative disc disease. You have the vertebral bodies. Between those are the discs. As you wear that disc out over time, the bones begin to approach each other. You get to a point where you have bone rubbing on bone. That forms bone spurs. Bone spurs can pinch the nerves. That can cause pain in the back, buttock, and pain down the leg. It can also close off the spinal canal. That is known as spinal stenosis. Spinal stenosis can be thought of as a blockage between the brain and the legs where the bone spurs have grown and have actually clogged off or pinched off the spinal cord. What we do is, using the XLIF procedure, we put the tube down to the disc that's involved. We place a new plastic disc. What that does is that restores the normal height and alignment, eliminating the pressure on the nerves, eliminating the back pain, eliminating the blockage, and getting rid of the pain in the back, buttock, and down the leg. This is spinal malalignment. It's called spondylolisthesis. It's where the vertebral bodies themselves do not line up. Typically, the spinal canal has the bones lining up. If one slips on the other one, it forms like a guillotine and will pinch the spinal cord. So this is the front, that's the back, these are the bones in the back, and we're looking at the spine from the side. This is an MRI. Here you see this bone lines up with all of these, but is slipped on this one. So it's pinching off the sciatic nerve. Obviously, this patient would have back pain and pain radiating down the legs. Typically, it's going to be more on one side than the other, even though looking at the studies, it kind of looks like it could be either side. This is an x-ray. The way we treat that is, once again, we put in the plastic disc, it restores the normal height and alignment, and it eliminates the pressure on the nerves. The last process I was going to talk about is scoliosis. Normally, the spine should be straight. You can get scoliosis like this. The way that happens is, as the discs collapse, they don't always collapse evenly, and they'll wear out more on one side than the other side. The example I usually use is, for example, somebody wearing out their shoes. As you walk, you may wear out the outside of the shoes quicker than the inside of the shoes. And the more you wear out on the outside, the more weight gets shifted to that side, and the quicker you wear your shoes out. And the discs do the same thing. As the discs collapse, they tend to pinch the nerves on that side. The way we do the XLIF is we make an incision there, the tube goes down, and we put in a new disc at various levels. Every time you put in a disc, it straightens out that level. So you can straighten out the spine kind of by unzipping it. You put one in, you put the next one in. In a case like this, you would not really have to, replace all the discs. Normally you would pick 1 or 2 or 3 of the discs in the middle, and that would give you adequate alignment. Thank you very much for coming, and I hope I answered your question.